Good morning, everyone. Welcome to today's webinar. No Mo FOMO, in case you missed it. Recent changes in guidelines, new publications, and updates from recent conferences. I'm Dr. Constance Benson. I'm a professor of medicine at the University of California, San Diego, and I'll be moderating your session today. And our presenter is Roger Bedimo from the University of Texas Southwestern Medical Center in Dallas. I will introduce him more completely in a moment. And as you're all getting ready to join us, I'm going to start going through some of our introductory slides. And first on our list is a listing of the financial relationships with ineligible companies within the last 2 years, mostly from our board members at IAS-USA and our presenter, moderator, and planners. And you can read that at your leisure. Our program today is CME accredited by the ACCME, and the IAS-USA designates this live activity for a maximum of 1.25 AMA PRA Category 1 credits, and the activity has also been approved for the same number of credits for ABIM mock points, nursing contact hours, pharmacotherapy hours, and pharmacy contact hours. These are the supporters and contributors for our conferences, one of which is this webinar, and we'd like to thank them for their contributions. And just a little bit of housekeeping for navigating this activity. There will be poll questions throughout the discussion. The poll questions will appear in a separate window that will show the question. You can choose your response for the poll, and the responses will be displayed after the poll closes. If you have questions for the presenter, please submit those questions using the Q&A button. We apologize in advance if we're not able to address all of your questions in the time allotted. I will say that we have about 20 questions that came in before the activity, and I'll try to get to those as well. And the chat is open, but please use the chat to start discussions with other attendees. Do not submit your questions to the chat, as the presenter and the moderator will, meaning myself, of course, will monitor the questions submitted to the Q&A. So I'd like to take this opportunity to introduce our speaker. Dr. Bedimo is a professor of medicine at the University of Texas Southwestern Medical Center and the chief of infectious diseases at the VA North Texas. His research interests include the analysis of rates and mechanisms of chronic complications of HIV disease and antiretroviral therapy, as well as the contribution of HCV co-infection on HIV-associated morbidity. He's the clinical research site leader for the AIDS Clinical Trials Group network at his institution and is a member of the Department of Health and Human Services HIV Treatment Guidelines panel, and an expert in many of the areas he will be covering for us today. So I'm going to turn the program over now to Dr. Bedimo.
Thank you so much, Dr. Benson, for the kind introduction, and welcome to all attendees to our presentation today titled No More FOMO. I take it that everyone here has FOMO, and we'll hope to alleviate the FOMO in a little bit. Let's see. Oh, nice. And these are my disclosures, as you can see. And the objectives today, I don't intend for you to read all of this on the chart, but we would like to describe a bit of our project towards ending the HIV epidemic with special focus on pre-exposure prophylaxis and how we can improve it. Describe new data for the management of both treatment-naive and treatment-experienced patients, to summarize data on prevention and management of OIs, and to describe recent data in the management of non-AIDS complications of HIV disease. And finally, we will touch on the management of COVID with antiviral agents, as well as prevention of COVID with vaccine and efficacy analysis that are recent. So this is what we're gonna progress on as an outline, progress towards ending HIV epidemic, management of treatment, experienced and naive patients, prevention and management of OIs, non-AIDS complications, and updates on COVID. Let's start with this pre-test question. And this is a question of a 28-year-old man with no noteworthy past medical history who has had 3 bacterial sexually transmitted infection diagnoses in the past 6 months. And he is offered appropriately pre-exposure prophylaxis with tenofovir disoproxil fumarate, but he declined because of reports of adverse effects associated with TDF-FTC PrEP. Which of the following is true regarding these patients' concerns? A, TDF-FTC PrEP is associated with statistically significant decreases in bone mineral density by week 24, and those decreases will progressively worsen thereafter. TDF-FTC PrEP is associated with lower levels of low-density lipoprotein cholesterol. C, FTC PrEP is associated with decreases in both fat mass and lean mass. And D, switching from TDF to tenofovir alafenamide, tenofovir alafenamide for PrEP was associated with a non-significant increase in estimated glomerular filtration rate. So that's the question. Please vote, and we will revisit the question at the end of the presentation. The second pretest question is a 60-year-old man with HIV infection since 1996, and he has been virologically suppressed on a stable antiretroviral therapy for the past 10 years, but has noticed increase in frailty, which has caused concerns about his survival. He remembers losing most of his friends to AIDS and other complications. Which of the following would you tell him regarding people with HIV who are on treatment today and virologically suppressed on treatment? A, the survival gap between people with HIV on stable antiretroviral therapy and the general population had narrowed in the past, but has not done so in the past 2 decades. B, AIDS-related conditions remain the main cause of morbidity in people with HIV on antiretroviral therapy. C, there is no difference in the rates of comorbidities between people with HIV and the general population. D, recent data show lower incidence of breast cancer in women who have HIV who are older than 50, and also lower rates of prostate cancer in men with HIV who are older than 50. Please vote. Again, after we cover the material during this webinar, we will revisit these questions at the end. So number 1 is progress towards the end of the HIV epidemic. We will look at the regional trends and PrEP guidelines, as well as metabolic effect of PrEP. This is a byproduct of lack of testing during the pandemic. At the upper left side on your screen, this spurious finding of a decrease in HIV incidence in 2020 was simply due to lack of testing, as attested by a subsequent increase, 18% in 2021, and we're waiting for data for 2022, and we hope it's not going to continue an upward trajectory. On the right, you see the regional differences, and it's exactly, you see that slightly more than 50% of cases, new cases being diagnosed in the South in purple. And so we have to have continued vigilance on these regional differences and address them, especially with the ending the HIV epidemic initiative has focused on 50 counties that are counted and 7 rural states that are counted for half or more of the cases. And this is reinforcing that thinking. One of the pillars of the ending the HIV epidemic is pre-exposure prophylaxis. And in the past year, there was an updated U.S. Preventive Service Task Force guidelines on PrEP. And as you can see here, the single indication is that adults and adolescents weighing at least 35 kilos at increased risk of HIV acquisition should be prescribed pre-exposure prophylaxis, period. I put 4 points at the bottom to illustrate the changes that we should acknowledge with these new guidelines. Number one, there is inadequate evidence on any risk assessment tools for HIV. Let's just consider everyone as being at risk, even if some are at greater risk than others. So we should not use any risk assessment tool to decide whether somebody should be on PrEP or not. Number two, there is no age cutoff for PrEP consideration. This is significant because HIV diagnosis is frequently delayed in older individuals, 55 or older. Number two is that older adults appear to have an even steeper CD4 count decline over time. So the earlier we diagnose them, the better. The third point is that gay, bisexual, and other men who reported male-to-male sexual intercourse are at higher risk, accounting for 71% of new diagnoses in 2021. So even if everybody is at risk, we should pay special attention to those populations that are more at risk. So reassessing barriers to PrEP is incredibly important. One of the biggest barriers of PrEP, you're looking at it, us, because we do not, because of some concerns for side effects, lack of familiarity, and others, prescribe PrEP enough for people who need it. However, if we did so, we will save lives. So generic oral pre-exposure prophylaxis every 3 months, with every 3 months screening, will be cost saving compared with annual screening alone over a range of HIV incidences. Now, PrEP would be cost saving even with what we know to be a true statement in PrEP is that there is a high rate of discontinuation and there is a low adherence. Despite that, it's still something that is cost effective that we should be prescribing. And this is new data. Now I'm gonna present data from 2 different studies. One, a trial, one of the earlier ones, showing efficacy of TDF-FTC PrEP versus placebo, also called IPREX. Why do I go back to this data? Because I want to alleviate our concerns about the appropriateness and the safety of PrEP. A reanalysis of this old study in 2015 showed that in green at the right bottom, that there are small but statistical significant decreases in bone mineral density when you initiate PrEP with TDF-FTC. However, this stabilizes afterwards, thereafter. So significant decline, even if it's small, by week 24, stabilization thereafter. This really mirrors what happens with the use of the drug for HIV treatment in people with HIV. The second analysis of the same IPREX, published 3 years later, revisits another metabolic complication of TDF-FTC, showing here that there is a significant difference in LDL cholesterol with lower LDL cholesterol in weeks 24-48 after initiating PrEP with TDF-FTC. While that is true for everybody who initiates TDF-FTC PrEP in the blue line, it's especially true in those whose plasma levels show that they were adherent to FTC TDF. Because if you're adherent to FTC TDF, that's the green curve, you have a lower levels of these lipids, both total cholesterol and LDL, than people who were not adherent or who were not on TDF-FTC, i.e. were on placebo. The second group of data that we, and then the third thing to say about IPREX is the change in fat. You see that on the right side, you have change in in body fat, and then in the left side, lean mass. You see no significant difference in those curves in the change in lean fat, lean mass, but significant decreases in total fat in those who had a higher or detectable levels of TDF while on PrEP. Those who do not have detectable levels have the same changes in total fat as people were on placebo. Another consideration that people have had was whether the newer formulation of tenofovir TAF was associated with an increased incidence of hypertension and certain initiation. This data comes to us courtesy of a Kaiser Permanente network. And so this is observational data. I want to emphasize that this has not been observed in the registration studies of TAF for PrEP. That is a DISCOVER study that compared TAF with TDF. However, in this cohort, where they had in these two cohorts of people who did not have hypertension or statin prior to the initiation of PrEP, they found that there was a significantly higher risk of hypertension in those who had TAF compared to TDF. There was also a higher incidence of statin initiation in those who initiated TAF PrEP versus TDF PrEP. Again, we revisited IPREX that compared TDF with placebo, and now we're looking at some newer data comparing TAF versus TDF PrEP, but contrasting it with the registration studies or discovery. Again, in the Kaiser Permanente of Southern California, much more recent data, a month and a half ago, showed that there is those who switched from TDF to TAF for PrEP, because some people do that. There was a non-significant increase in EGFR. So if this data was to be confirmed using larger cohort, it will be unnecessary for people to switch from TDF to TAF for PrEP if that was to be done to improve renal function. So there is an improved survival of people with HIV on ART, and this has been documented by two groups of studies. This is the first type of study that looked at population-based cohort study of survival in people with HIV and uninfected control who matched by age and sex. This was in Denmark. You see that if you start with the gray curve, which shall track the survival of people with HIV from 1996 to 1999, you will see that it was much lower than 5 years later, 2000-2005, that's the blue curve, and which was even higher in the green curve from 2006-2014, all compared to the general population from 96 to 2014 in the orange curve. So the gap had narrowed from 1996 to 2014. Now, what happened since 2015? Things had continued to be better. If you focus on the curve on the left, which is women, you'll see that the solid lines are people who acquired HIV after 2015. You will see that there was a lower survival than those, sorry, there was a greater survival than for those who acquired HIV before 2015. Those were the dotted lines. There's another point to be made here, is that there was a higher survival of people who acquired HIV through heterosexual sex compared to IV drug use. The third point here is that if you compare either group, IVDU or heterosexual sex, to the general population, that survival gap had continued to narrow, but hasn't completely closed. So even after 2015, we had a narrowing of the survival gap between people with HIV and the general population. On the right for men, just another group was added, that of people who have sex with men, but there was no significant difference in the message. So there has been progress. Progress continues to be made in the management of both treatment-naive and treatment-experienced patients. The one issue that we want to examine is the paradigm shift of departure from our 3-decade-long use of 3 drugs to treat HIV as the sweet spot to 2 drug regimens, both for treatment-naive and treatment experience as a switch strategy. And these are the studies that we see that have showed us options for 2 drug regimens in people with HIV. We have had a multitude of them, from boosted PI and 3TC to dolutegravir rilpivirine to dolutegravir boosted darunavir to dolutegravir 3TC, dolutegravir FTC, and what I will focus on in the next few slides, cabotegravir rilpivirine as a long-acting injectable option. And these are the studies that have led to proof of the efficacy and safety of that modality at last for people who are already virologically suppressed, that switch to that, and flare for people who are first suppressed on oral regimen and then immediately transition to long-acting injectable. Now, we have to remember that these options should be explored only in people who do not have active co-infection with hepatitis B, though would need to continue on at least 2 agents that are active against hepatitis B. That being the case, the current FDA-approved indication for long-acting injectable cabotegravir is for virologically suppressed patients who desire ART switch. And again, the data came from Atlas 2M, and then another newer study, SOLAR, that we did not discuss. But who's left behind? People with suboptimal adherence to oral therapy. Sometimes it's important to realize that, can we do better with these people? Can that modality be extended to them? It's not FDA approved, but studies continue to be presented and published that suggest that we may want to consider these people. The other one that we're not going to discuss more is a temporary inability to take oral medications. Now, we could consider that when somebody is in the ICU with on ventilator and other things, that this is an important thing to consider. That now we can probably switch them to IV to parenteral ART, but that's something that we should consider. Now, let's focus on long-acting cabotegravir rilpivirine in indications other than that they are FDA approved. This is long-acting cab rilpivirine implemented using rigorous protocol, including bi-weekly patient review with significant support services provided at Ward 86 in San Francisco, and cabotegravir rilpivirine inclusion criteria. Virology suppression was not required, and no rilpivirine mutation or instant mutations were to be confirmed. So those patients had to agree to come to clinic every 4 weeks, provide contact information, and receive outreach from staff. And then outreach was important in making sure that they did well. So 76 patients with virologic suppression prior to switch all remained suppressed during follow-up, which is good. But more importantly, 55 of the 57 patients who were viremic at start achieve virologic suppression. Now, one can argue that these are 55 patients that would not otherwise have been suppressed, and these are 55 patients who probably would have a progression of the HIV disease with adverse outcomes. So it's possible that this is a modality that will be salutary to a number of patients who do not meet the current FDA indications. Other data came to corroborate this, and one is the OPERA cohort that analysis of the OPRA cohort included people who received first-line cabotegravir ripivirine between January 21 and March 22, with follow-up through March 15, 2022. Those were 321 patients. And I'm just put here in quotation one of the findings of the 36 individuals with viral suppression, with viral load greater than or equal to 200 copies at initiation, and at least one follow-up viral load. 94% of them achieved undetectable viremia at the last measurement. So this is, again, a group of people who should not receive cabotegravir ripivirine per FDA indications, but that benefited. The second study was a JABS cohort in Australia, and this is 60 patients with quote-unquote complex medical needs, social vulnerability, and historical non-adherence who were supported in the switch to long-acting cabotegravir ripivirine and when suppressed, and has similar adherence and efficacy rates at those in phase 3 clinical trials. So this is something to suggest that to keep in mind that we will see others. The last study is the Latitude or ATTG 5359. The data are eagerly awaited because this study had 4 phases. In phase 1, people receive incentives, including financial, to remain adherent. And then in phase 2, they were randomized to either long-acting cabotegravir ripivirine or oral agents. So we'll see. The next phase of our discussion is going to be on the prevention and management of opportunistic infections. We'll first look at a sobering data on the increase in syphilis. You've all probably have seen that. And then HPV vaccination and herd immunity, and then finally dexamethasone in TB meningitis. This is quite shocking and something that should be cause for alarm. There is a dramatic increase in congenital syphilis in the US, over 10 times since 2012. And that is, by and large, 90% of that increase can be attributed to lack of timely testing and adequate treatment of syphilis in pregnant women. And so this is something that should be really addressed. And it's especially important because we do not have penicillin. That penicillin shortage is concerning. And now the recommendations is to keep all the penicillin you can put your hands on to reserve it to pregnant women because others may have other treatment options. But those treatment options are not numerous. There is few data on ceftriaxone in neurosyphilis. Early trials demonstrated efficacy of azithromycin, but recently there's a high prevalence of macrolide resistance. And then the efficacy, effectiveness of doxycycline observed observational trials also has scarce data on neurosyphilis. But by and large, doxycycline is the go-to now in the era of penicillin shortage. Then came this data published last month that tried to use linezolid versus penicillin in syphilis. And the composite endpoint was either clinical cure, serologic cure, or absence of relapse. And linezolid was not found to be non-inferior, i.e. it did not perform as well as penicillin. The difference in proportion of reaching that primary endpoint was minus 29.6%, almost 30% less efficacious. So this is probably not the answer to our penicillin issue, so we need to continue to be vigilant. Now, we know that the term herd immunity got a black eye during COVID, but this is a good way of looking at herd immunity. HPV vaccination in girls and boys has been shown to be effective in preventing cervical cancer in girls and women. So this is an examination of the long-term effect of HPV vaccination on the ecology of untargeted HPVs. Again, the HPV that are oncogenic, that were therefore vaccine targeted, included HPV 16, HPV 18, 31, and 45. 2 strategies were looked at. The first strategy was a gender-neutral vaccination, i.e., both girls and boys were vaccinated. The second strategy was vaccinating girls only, and both of them were compared to no HPV vaccination at all. The first thing is that the community-level depletion of the vaccine-targeted HPV types, 16, 18, 31, and 45, was documented as early as 4 years post-vaccination, and that ecological diversity increased at 8 years post-vaccination. But more importantly, if you looked at the gender-neutral vaccination group, i.e. boys and girls were vaccinated, a 50% vaccination coverage was sufficient to nearly eliminate the occurrence of high oncogenic HPV types in the targeted population. That same resource needed a 90+% vaccination coverage if you targeted girls only. So targeting both girls and boys, you did not need to reach nearly as high a coverage to eliminate or virtually eliminate the oncogenic HPV in the target population. So this is important to consider when people are debating whether boys and girls should be vaccinated to prevent cervical cancer, HPV-related cervical cancer. So now we know that HPV would protect against development of cervical cancer. The question that remains is that for those who already had precancerous lesions and had been vaccinated in the past, would HPV prevent the progression of those precancerous lesions? This is what this newest study in December has shown. So HPV vaccination actually did reduce the risk of progression from CIN1 or CIN2, cervical intraepithelial neoplasia, grade 1 and 2, to grade 3 or greater. So even if HPV vaccination was not sufficient in preventing you from developing these precancerous lesions, if you did develop them, you are at lower risk of progressing. And this data is in the general population with two points to be made here. A lot of the times, almost half of people in the general population that have these CIN1 or 2 lesions will spontaneously regress. That regression is less likely to occur in people with HIV. So the benefit of vaccination is likely to be greater if you look at this study in people with HIV than in the general population. Now, this TB meningitis is probably the deadliest of opportunistic infection, thankfully not seen in our shows as often as in resource-limited settings. And tuberculous meningitis mortality can exceed 50% even with adequate TB therapy. So one thing that has been considered is adjunctive glucocorticoid management to anti-TB medications, but there was no efficacy or safety data until now. A few months ago, 520 adults with TB meningitis were randomized to receive placebo or dexamethasone, and there was no difference in mortality between the dexamethasone group and the placebo group. And again, please note the really high mortality rates here, 44% and 49%. It's an incredibly severe opportunistic infection. On the silver lining, there was also no greater risk of adverse events like neuroiris. So, and now from the AIDS-related complications and OIs to non-AIDS complications of HIV disease. And we know that in people with HIV who survive longer, since we see that the survival gap has continued to narrow. But what drives the remaining gap is these non-AIDS complications, and can we do better in mitigating them? That's the next question. So the forecasted prevalence of comorbidities and multimorbidity in people with HIV is substantial. Let's first look at the old data, which showed that age-related comorbidity burden is higher in people with HIV compared to a general population of the same age. Now we have this forecast that came out last month that by 2030, in people with HIV, almost half of them will have 2 or more physical comorbidities. and almost 2/3 of them will have at least one mental comorbidity. These are things that will add up, that will cause polypharmacy, that will cause increased frailty, and that by and large will drive the survival of people with HIV on successful antiretroviral therapy. So we need to pay special attention to those. When it comes to non-AIDS cancer, which shares the stage with cardiovascular, cardiometabolic risk in driving mortality in people with HIV, the trajectory of these non-AIDS cancers is not as straightforward as one might have looked at first glance. And the data that was published last month maybe comes close to explaining why we have such a disparity in looking at the risk ratio of these non-AIDS cancers between people with HIV and the general population. Now, you can see easily that the dotted line, which represents people without HIV, mortality and cancer rates increase over time as they age. But the shapes of the curves in people with HIV, the solid lines, for AIDS-defining and non-AIDS-defining cancers are not as straightforward. Now, AIDS-defining cancers are more common among people with HIV at a younger age. And non-AIDS-defining cancer become more common over age 50. And the similar incidence in non-AIDS-defining cancer in people with and without HIV after 65. So if you stand where I am now at the VA, where the median age of your population with HIV is 60, you will have a different picture of non-AIDS-defining cancers than somebody looking at people with HIV in a clinic where the median age is 30 or 40. It's important to take into consideration. So this nuance picture is even more important to consider if you look at site-specific non-AIDS-defining cancers. So you can see here that the incidence of lung and head and neck cancers is always higher for female patients. These are Medicare beneficiaries with HIV, while the curves cross for male patients. You can see that in the highlighted box in red at the left, we have a lower incidence of breast cancer in females over age 46 that have HIV compared to those who do not have HIV. And when it comes to men, there is a lower incidence of prostate cancer in male with HIV over 50 compared to male without HIV over age 50. So again, when you see people in the VA, you may want to see that this is an important distinction that is not well apparent in when you lump everyone and say that HIV is associated with a higher risk of such and such cancer. Now, INSTIs are now the preferred agent for initial HIV therapy for most patients. The concerns have come when INSTI including ART, has been associated with increased weight gain. And with that increased weight that people have observed in some studies, come a consideration, is there an increased risk of metabolic complications? Prior to this data a year or two ago had looked at dolutegravir and adipocyte toxicity. This data here presented at EACS in October last year looked at bictegravir in two instances, looking at it in mice and also in human hepatocytes. The conclusion from these studies were that bictegravir altered glucose tolerance in mice and altered glucose metabolism in human hepatocytes. If these studies are confirmed, both in vitro and in human studies, it may be one of the mechanisms that we may need to pay attention to when it comes to cardiometabolic risk associated with ART-containing integrase inhibitors. Now, can we do something with the weight gain that we have been experiencing in people with HIV, especially those who are receiving INSTIs or TAF? Now, we have looked at the general population for guidance. In the general population, all the rage, of course, has been on GLP-1 agonists, semaglutide being one of the first. And in the latest study presented 2 or 3 months, published 2 or 3 months ago in New England Journal of Medicine, it was proven that it's not just a cosmetic benefit of using these GLP-1 agonists. There was actually a lower risk of cardiovascular composite endpoint, i.e. Development of cardiovascular disease or death in semaglutide users compared to placebo users. Now, what is the case for people with HIV? One of the first analysis was done by Grace McComsey at Case Western, looking at semaglutide and weight and visceral adipose tissue in people with HIV. The conclusion was that semaglutide, yes, it also did decrease weight in people with HIV. It decreased visceral adipose tissue. That's the good news. But it also did decrease lean fat mass. That's the bad news, because we don't know if decreasing lean fat mass in people with HIV as they get older would further the risk of frailty and other age-related complications. So that is sort of a cautionary tale. I think it would be good to see whether we see other data that look at semaglutide use in people with HIV in terms of fat mass, lean mass, and lipoatrophy. Now, let's conclude with COVID-19. There is a lot of COVID fatigue out there. People with respiratory illness, influenza-like illness, are getting reluctant to get tested for COVID. Also, those who are actually found to be infected are getting reluctant to take medication for COVID. And even more worrisome, vaccine hesitancy has done nothing but grow. So let's visit some data that could help us assist our patients. Number one is this newer vaccine, 2023-2024, was based on the circulating XBB strain, and led to the CDC significantly streamlining the vaccine recommendations. Now, this is very nice and neat now. If you've been unvaccinated, take 1 dose of the mRNA vaccines, Moderna or Pfizer, or 2 doses of Novavax. And if you have been vaccinated, 1 or more doses of any mRNA vaccine, take another one, the newer formulation, and so on and so forth. So if you're immunocompromised, the new guidelines suggest that you take not just 1 dose of the mRNA vaccines, but 3. And then if you were previously vaccinated, you see the graduation of recommendations on the doses based on how many previous doses you've taken. So these are much more streamlined for those of you who have been used to kind of trying to look at and make sense of the recommendations for vaccines for COVID. Now, are these recommendations sound? The first thing we'll say is that, yes, the data just 2 weeks ago from the CDC has confirmed that the circulating virus now is JN.1. If you look at the vaccine efficacy of that XBB-based vaccine, it's about 54% in protecting against JN.1 today. So it's still relevant. Please still use it or still recommend it. The second thing is that for those of us who are immunocompromised, these are the left behind of COVID, because the preventive measures that we have, i.e. vaccine, tend to not work so well for them. And even the monoclonal antibodies that we're using for pre-exposure prophylaxis, the ones that are available now tend not to work, although newer ones are coming. But if you look at this data that came out just 2 years ago, it says significant increase in antibody titers for this allogenic hematopoietic stem cell transplant recipients after 3 doses. So that really reinforces what the CDC has been saying. Even more so, the newest data shows that in December of last year, if you use those 3 doses in stem cell transplant participants, the levels of the titers that you will achieve will equal that of people who are not immunocompromised. So they actually catch up to those if you give them 3 doses. Now, another consideration that we don't know what trajectory will take is that of post-acute sequelae or long COVID. And this CDC data shows that it was tracking long COVID in households. And the latest data suggests that the percentage of individuals with post-COVID conditions may be declining from 35% to 27%. More data is needed to show it that trend continues to be downward. That would be a good thing. However, that reluctance to take HIV, COVID medications is something that I would like to address last. So this data is the older ones, is that the Medicare enrollees age 65 or older with COVID-19 between January and September 2022. And they looked at post-COVID conditions 4 to 12 weeks post-infection. There was an absolute risk reduction of post-COVID conditions by 2.7% in those who receive antivirals and 0.8% those who receive with nirmatrelvir ritonavir, and 0.8% those who receive molnupiravir. So at least one symptoms of PCC occurred in 14% of untreated patients. And so it's important to consider that just maybe clearing the virus with antivirals during the acute phase of COVID just might be able to prevent post-COVID conditions later on. Same thing that was found in antiviral therapy with ensitrelvir, which is not commercialized in the US, but in Japan. But in this study of ensitrelvir versus placebo, post-acute sequelae were a pre-specified endpoint, and it was shown to be reached in that people who receive ensitrelvir had a lower risk of post-acute sequelae from COVID. I'm still waiting for this data to be published. If it has, I don't know yet, but it was presented in CROI last year. And at the VA, near and dear to my heart, we have the VA cohort analysis that shows that people who had positive SARS-CoV-2 testing between January and December 2022, it showed a reduction of post-COVID-19 conditions with nirmatrelvir treatment versus no treatment. Again, observational data from the VA. Now, we had EPIC-HR, which looked at the efficacy of nirmatrelvir ritonavir, and another analysis of EPIC-HR looked at whether virologic rebound was less or more likely to occur in people who received nirmatrelvir ritonavir. And it found that rebound was not higher, the incidence of rebound was not higher in people who received nirmatrelvir ritonavir compared to placebo. However, this is the latest analysis less than 2 months ago, an observational study of 127 participants, 72 of whom received a 5-day course of nirmatrelvir ritonavir from March 22 to May 23, and they received 3 or more swabs in the first week and weekly swabs thereafter. They found a much higher risk of virologic rebound with nirmatrelvir ritonavir, 20%, compared to no treatment, less than 2%. Now, this is concerning. It's not clear why the disparity of data between studies on the risk of virologic rebound, and it has been a reason for reluctance for some physicians and patients to either prescribe or take nirmatrelvir ritonavir, as virologic rebound may be more common in those who got treated. Again, there has not been concordance of findings on those. On the one hand, I presented data suggesting that antiviral therapy just might prevent occurrence of post-acute sequelae from COVID. And is this something that should cause pause in prescribing those? Many of us, myself included, I think not, because getting rid of the virus just might have beneficial effects. Then for those who develop post-acute sequelae from COVID, one of the most worrisome symptoms for many has been the post-exertional malaise and fatigue. And a lot of the times has been difficult to pinpoint. People used to run 4 miles can barely do half a mile, and after exercise, they just feel much worse than before the exercise. Some studies are now beginning to show that there is actually a physiologic and a pathophysiologic reason for that. The oxygen uptake is lower, VO2 max, in those who experience these findings post-COVID versus those who don't. And the gas exchange in the tissues is lower. So that all could justify or explain some of this post-exertional malaise. And hopefully we will find pathophysiologic mechanisms underpinning all the other post-acute sequelae from COVID, because that would allow us to measure the impact of therapeutic and preventive measures for them. So let's go back now and revisit the questions that we had when we were studying. This is the first one being a 28-year-old man with no noteworthy past medical history who has had 3 bacterial sexually transmitted infections that in the past 6 months and has been offered PrEP, is reluctant because of concerns for side effects. Which of the following is true? TDF-FTC PrEP is associated with statistically significant decrease in bone mineral density by week 24. That decrease will progressively worsen thereafter. B, TDF-FTC PrEP is associated with a lower level of LDL cholesterol. C, TDF-FTC PrEP is associated with decreases in both fat mass and lean mass. And D, switching from TDF to TAF for PrEP, the sort of not significant increase in EGFR. Please go ahead and vote again, and then we will discuss the correct answer. All right. So again, here the correct answer being B. We again talked about IPREX, which was a randomized RCT. I'm glad. So we have, sorry, I should have gone through the answers. So we have had IPREX here that showed that the randomized controlled trial of oral TDF versus placebo. Again, that showed that metabolic outcomes show a statistically significant decrease in BMD, but that plateaued thereafter. Another analysis of IPREX showed decrease in cholesterol, and there was decrease in TDF PrEP suppress accumulation of weight compared to placebo. And then recent analysis of Casa Permanente, so if a significant increase in glomerular filtration rate with TAF when you switch to it versus TDF. I don't know if I have the references here. Okay. Yeah. Next question is a patient who is a 60-year-old who is HIV infection since 96, virologically suppressed, unstable ART for the past 10 years, but has noticed frailty, which is concerning to him. Which was the following true? The survival gap between people with HIV, unstable ART, and the general population has not narrowed. To B, AIDS-related conditions remain a cause of concern. The main cause of morbidity in people with HIV. C, there's no difference in the rates of comorbidities between people with HIV and the general population. And D, recent data show a lower incidence of breast cancer in women with HIV who are older than 50, and prostate cancer in men with HIV who are older than 50. Please go ahead and vote. Let's see if we can get the results. Let's see. Okay, excellent. So that's the correct answer is D. Recent data showing lower incidence of breast cancer in people with HIV when they were older than 50. And so that's evidence here. And I think that that's important as you nuance discussion of the risk of non-AIDS malignancies in people with and without HIV. So that's the correct answer, and these are the references that you may visit. I think I'd like to go back to question 1 because I think that there was significant confusion about the answer to this question. And that was, I now realize it's my fault because answer D should be looking at whether switching from TDF to TAF was actually a significant increase in cardiometabolic. That's why a lot of people picked it, so that's correct. But I formulated this as non-significant, but was supposed to be that is actually significant. So the increase in EGFR, again, when you switch from TDF to TAF in the Casa Permanente, Southern California, was a non-significant increase. So it was not significant. So I apologize for the confusion, and that led to many incorrect answers. So thank you, and I hope we have at least a few minutes for more questions and answers.
Well, I'd like to thank Dr. Bedimo for an excellent presentation. You covered a lot of material and you generated a lot of questions. So I think we have an additional 15 minutes now to go over those. Let me first remind everybody, as you saw from the chat, that the slides and the recorded portion of this webinar will be available 24 hours after today's date and time, so tomorrow. And the link to get the recorded versions are in the chat if you're interested. So Roger, there were a few comments in the chat that I'll go over for you that you might have missed. And then several of those comments related to the need for also considering women who are sexually active to be candidates for PrEP, and agreeing with your points there. And a couple of people making the point that OBGYN care is sometimes not the place to have women access PrEP. And so a primary care physician or a HIV physician may be the better place to access PrEP for women if your local OBGYN community does not prescribe that. There were also a couple of comments about adolescents who are sexually active. I think you also made that point. Kevin Carmichael commented in the chat that recent CDC data suggest that HPV vaccination in the US in 2022 was only at 39%, and that there were significant differences in various subpopulations. I found your data on herd immunity and the relationship with a reduction in cancerogenic or oncogenic HPV subtypes to be fascinating. So that may be another important point for people to be aware of in terms of widespread use of HPV. So I'm going to kind of go back and forth between the written questions that came in before your talk and some of the questions that were generated in the Q&A during your talk. So I'll start with the Q&A, and one question from Susan Marshall. Why would you continue PrEP while a patient is in the hospital? Would stopping PrEP cause resistance in the short term?
Oh, I think really this is a good question. I don't it's the answer depends on what how you assess the protection from PrEP. So if you look at the oral PrEP, there is a time from when you start oral PrEP to when it's deemed effective from 7 days in the with sex to 20 days with vaginal sex. So stopping will mean that you know that this person, when restarting PrEP, there will be some time before they regain they gain effective drug levels. The second thing is that till there's no risk of any resistance if the person doesn't acquire HIV while in the hospital, and so that's important. Hopefully, people do not acquire HIV in the hospital. So when it comes to tail end, when you stop, of course, now with the injectable PrEP, you know that the tail will be longer, and that is more cause for caution.
That's great. We're going to talk a little bit about the HPV data that you showed and kind of bounce back and forth between topics because the questions didn't always come in order. So you talked about the HPV vaccination rates resulting in herd immunity and reducing cervical cancer. How about data on anal cancer? Maybe it's a bit premature for us to see that with anal cancers.
Yeah, I think it's a great question. In Scandinavia, where this data came from, that was not looked at. And we all know that the biology of cervical cancer is so similar to that of anal cancer that I don't see why that shouldn't be the same in that population. Again, it's important to know that pap smears and cervical cancer screening was recommended even before we had solid mortality and data. So it's just a shame that people are still struggling to practice the central evidence that when it comes to anal cancer. And thanks to the anchor study, and now we really are getting more solid data on the management of precancerous lesions and the anal pap smear in men who have sex with men. So it's possible that this data will translate, but I would be lying if I said I knew if there's any of such data with anal cancer.
And just to finish off the category of HPV cancers and HPV vaccination, does the age of vaccination matter in decreasing HPV after infection for those with HIV?
Oh, that's a great question. I think that the answer is likely yes. I would say likely because people will acquire HPV over time. If you don't vaccinate at that early age, it's likely that they would already have acquired HPV. That's the fact. That's why it's so important to follow the current recommendations. Unfortunately, in some places, it's not palatable to be vaccinating people who do not have sex yet. But this data, like in Scandinavia, clearly shows that this is what we should be doing.
Great, thank you. Let's move on to another sexually transmitted infection that you covered. Regarding syphilis increases, is there a benefit, or can you discuss any benefits or lack thereof of importing penicillin drugs like French extensiline into the US?
Yeah, well, this is way beyond my pay grade and beyond my expertise. I just think that it's sad that we do not have penicillin. It just doesn't make sense to me. And I hope it never makes sense to me because I don't think this type of stuff should make sense.
Yeah, and I think many of us are limited by what we can and can't import and prescribe for our patients. So it's difficult to have a blanket statement about trying to deal with the shortages. Let's move on to a little bit to some of the antiretroviral therapy data that you covered. Two kind of related questions I'll just give you right off the bat. Have there been improvements in the number of formularies around the country that include long-acting injectables? And aside from insurance, are there other barriers to care in providing long-acting injectables for people?
Yes, I think we are continuing to learn about long-acting injectables, not on efficacy and safety, which we have the trials to thank for, but on implementation. Implementation science is something that really got a shot in the arm with this availability of this, because it's a paradigm shift. And a lot of the complexities come from how do we move from somebody who comes to clinic every 3 months or every 6 months, depending on the stability, and gets prescribed pills that they take home with them, to somebody who comes to a healthcare facility to receive injections. How portable would that be if they travel? And how what is the guidelines? How do we plan for missed visit and other things? I think those implementation barriers are one. Number two is access, and if there's no shortage of possible barriers in having the medication stocked in the places that the patients can visit. I particularly welcome the possibility that with portability of healthcare, people would be able to show up in a pharmacy near them, and the injections can be received there, and the records of that injection be transferred to the providers to be recorded. And I think that implementation science is what we should be focusing on now. And thankfully, a number of studies on the implementation of long-acting injectables are being done, and some have been completed, and we will learn more.
Great. The next three are also kind of related to ART, but maybe you could comment on whether the oral lead-in period for the long-acting injectables helps to reduce treatment failure. You talked about several studies that are treating people who are not fully suppressed. What do we do about that oral lead-in phase?
Yeah, so it's a good question. Now, the challenges and what I call the mission creep of injectables to people who are not virologically suppressed come from this current recommendation. We asking people to show us ability to suppress the virus before they can earn the right to long-acting injectables. Now, if implementing the long-acting injectables come by way of an oral lead-in, which is something that they had trouble with another regimen, I don't personally see how that would make things better. And so I want to lean into the data that showed the safety of direct to injectable, and to say that this is indeed what we should be doing, and this is what was done with the latitude studies, which again we're eagerly awaiting. This is what was done in the JAB study in Australia, as well as the Ward 86 study in San Francisco. I think that in those difficult to manage people, i.e., we have had a hard time getting them virologically suppressed and or to attend clinic on a regular basis, it may not be unsafe to switch them to injectables.
Great. Kind of sticking with ART for a moment, but sort of sliding into the metabolic and other complications of ART. Is there a future class of non-INSTI medications that you think will help avoid metabolic side effects?
Oh, yeah, that's a good question. So if you were following HIV guidelines for the past couple of decades, you we have seen that there was a gradual expansion of options for um, treatment naive people with HIV to a gradual narrowing of the options for treatment naive people with HIV for most. And now we're left with, by and large, integrase-based regimens for most people with a few alternatives. Now, with the concern with cardiometabolic complications of INSTI, which remain to be well codified and proven, what can we fall back on? I would be remiss to, I'm loath to ask people to switch back to regimens that could have even more possible adverse effects and than INSTIs. Again, that definitely with GI and metabolic risk, PI-based regimens are probably not the answer. In terms of NNRTIs, going back to the older ones with possible neuropsych complications, is probably not the answer for most. We still have to understand what newer NNRTIs would do in terms of mitigating the possible cardiometabolic risk of INSTIs. The other thing I would like to say to conclude is that we know that INSTIs have been associated with weight gain. And again, that may be confounded by the fact that other drugs that people switch from to either INSTI or TAF were suppressing weight, i.e. TDF and efavirenz. But we also know that, on the other hand, INSTIs have been associated with in some studies with cardiometabolic risk. The two are not necessarily associated. We all know that you have to eat burgers for several years and gain weight for a lot of years before you had an MI. So if you had an MI within weeks or months of taking an INSTI, probably not because you gained weight during that time. So there's a lot of amalgamation we should avoid doing, and we need to better understand. I share the frustration of many that 5+ years into this weight gain issue, we still have very few answers. And I hope we get some soon.
Okay, we've got about 3 minutes left for Q&A, so I'm going to move on to the COVID questions. There are two sort of related ones, so maybe I'll ask both of those and you can fit them into your answer. One is, would treating longer with an antiviral prevent virologic rebound in COVID and also provide the benefits in reducing post-COVID syndromes? And does the earlier administration of nirmatrelvir impair to antibody or T cell responses in COVID infection? Is that the reason why there's higher rates of rebound?
Yeah, the answer is a qualified yes to both. To the first question, longer courses are being looked at, especially in immunocompromised people, because they tend to harbor the virus for a longer time. And while not FDA indicated or FDA approved, but a lot of people are moving on to 10 days or more of antivirals in these patients. So that could decrease the hasten virologic clearance and probably increase rebound. Now, for preventing post-acute sequelae, I don't know. I don't know that there's any data on that. For the second question, when this data on nirmatrelvir, ritonavir, and rebound was parsed, it appeared that the people who got the drug within the first couple of days tend to have a higher risk, probably because they did not, then this is a hand-waving explanation, it didn't let the natural immune response to COVID to mature. These are all possibilities. I can't say that it's a proven phenomenon.
And thank you. I think both of those answers are very cogent for our times. What are the current recommendations for COVID boosters? So how often should everybody get a booster?
Yeah, again, I don't know that anyone has the answer to that is clear. We know that the antibody response wanes over the 4 to 6 months. And so far, I don't know. Dr. Benson, let me know if you know whether we already have a clear recommendation on frequency of administration of COVID vaccines. I believe that it may be better to mirror the influenza immunizations, although seasonality of COVID is less clear.
Yeah, I think that's an area of ongoing discussion, and we don't have clear guidance at this point. I think there's a plan in the footing by a couple of guidelines panels I'm aware of to suggest that you get an annual COVID booster at the same time you get an influenza booster, but that hasn't yet come out as a formal recommendation, and which booster and which population is likely to benefit the most. So I think we're still waiting on data for that. So I think we are at our time limit. And I know we haven't gotten to everyone's questions. There have been a number of other questions that came in early, and just a couple in the chat in the Q&A. I think we covered most of those. So if you would like to have your questions answered in writing, I'm sure we can forward those on to Dr. Bedimo and have him offer his opinion on some of those. And I will just go on to conclude our program today. Thank you for your attention. And hope I'm not forgetting anything, but there are a few slides that our staff are going to show you as you're leaving the program today, just to provide you with information on evaluations and future programming from IAS-USA that may address some of these. One in particular is the Mpox one. We didn't cover Mpox in this webinar, and there were a few questions that came in about it. So I hope you'll all tune into that one. There were also a couple of questions on new drugs on the horizon, and there's also an upcoming webinar on that topic if you're interested. So thank you all for your attention, and I think that's it for today's program.
Thank you, Dr. Benson.